Hello, this is our Dental Talk Without Secrets, and today we're going to be talking about how to restore one dark tooth, which is this case here. This is always a challenge. I know that many people, when look at a case like this, may think, there's not just one problem here. The gingival level from one side of her mouth is different from the gingival level of the other side of the mouth. And maybe, you could restore all the teeth, give it more volume or something like that. You could make some kind of a DSD, a digital smile design or something, and come to the conclusion that you could do like 6 veneers, 8 veneers, 10, or even 12 veneers. But where I live in Brazil, that is not always feasible because patients many times come to you because the patient has just one problem, and in this case, one dark tooth. That's it. And the challenge here is not just to cover up that tooth that has that different color with a more aesthetic composite or with a more aesthetic ceramic material, whatever it is. But it's also masking that dark substrate and reproducing all these characteristics that the other central have. The other central have areas of low value, like a kind of grayish hue, has some white spots, has some brown spots, has a crack which should be reproduced. So it's not just a matter of covering up the other tooth, but it's also to replicate all these characteristics that the other central have. You can see also here that you have you had a diastema in this case. Okay, there was a diastema, in this case, and the diastema closure was done with composites. I'm going to redo that, especially on central, the right central. It's the only restoration I'm going to do in that tooth. You have some stain at the margins, at the restoration close to the gingiva. Okay, so you have here the characteristics. And also, what I do in a case like this, where I have to reproduce a tooth, where I have to replicate a tooth with so many details, I get a picture like this one, a very good picture. I invert it because the tooth I want to reproduce, I put it into the place of the tooth that I'm going to be working on. Uh, and I also do a drawing with the steps and with the details that I have to copy. Okay, so I in a paper I draw, the tooth, and I mark where the crack is, where the low values areas are, where the brown stains are, where the white stains are. Okay, I make a scheme on how to do that, and also I print the picture, and I'll have both right in front of me while I'm doing my work. Okay, so here we're going to start. The first thing we're going to have to do is a preparation. This is the typical case that the tooth has to be prepared because both centrals are exactly at the same level. I can't just build up a restoration on top of that tooth, okay? And if you say, oh, let's build on both tooth, the volume doesn't allow. I have to prepare it. And another important thing, this is a vital tooth. It's not an endodontic treated tooth, okay? It's a vital tooth. Usually in a case like this here, what I do is I do bleaching in only one tooth, home bleaching, okay? Walking bleaching, no, not walking bleaching, sorry. A home bleaching, okay? A tray bleaching, a home bleaching in just one tooth. So I make a tray, and on the teeth, besides the tooth I'm going to be bleaching, I make a hole in the tray so that the gel can skip out of the tray, and I put the gel only in one tooth, and I do that for like 2 months, give it or take. Okay, and usually we get a good result, but we didn't get in this one. Okay, we didn't get in this case here. So we're going to do a preparation similar to what we do when we're doing a ceramic veneer. Okay, this is a depth cut burr of 0.5 millimeter. So when you put it on the tooth, as the X of that burr, where you don't have the diamonds, uh, touches the tooth, it will prevent it from going deeper. So the groove that I make there is 0.5 millimeters deep. Okay, so I get a marker and I will paint at the bottom of that groove so that when I'm preparing the tooth, I know when I reach the desired depth. Okay, and now with the long burr, I will be preparing it. Of course, here I have a challenge because I need space, but I also want to preserve, as much as I can, sound, not anymore sound enamel, but enamel from the patient. Okay, so I need space from one side because the more space I have, the easier will be for me to reproduce all the details of the other tooth. But the more I prepare, the more enamel will be lost, okay, and the more I take the enamel out of the tooth, what's going to happen is that the dentin will shine through more, and dentin is the structure of the tooth which is responsible for the hue, the color of the tooth, which is dark on the tooth. The dark part of the tooth is the dentin, not enamel. So if I'm removing enamel, the tooth will look darker, okay, because the dentin will show through. So you see that I'm preparing it, and when I reach those marks that I made, I will probably be not, I won't be exactly 0.5 millimeter thick. Of course, I'm going to be more than that, probably around 0.8, 0.9, which is the depth that I want in this case, okay? So you see that everything I do in dentistry, I always say that, I always do it looking through a microscope. All the restorations, all the preparations, everything I do in my practice, I do looking through the microscope. So the image that you see here in this video is exactly what I'm seeing while I'm working. And you can see here that I'm doing my preparation very close to the gingiva. I have a retraction cord 3.0 Ultra Pack from Ultradent inside the gingiva, okay, just to retract it a little bit, and I'm going to take my preparation very close to the gingiva and very carefully not to harm the gingiva. And also on the sides, I want to take my preparation close, very close to the contact point, okay? I'm not going to break the contact point, but I want the preparation very close to that, because on a side view, I don't want the interface between the restoration and the tooth to show through, okay? So this is I'm finalizing my preparation, okay? Getting into the proximal areas, okay, on the distal, on the mesial, both of them. And I'm also going to be checking on the occlusal surface if I have enough space, okay? So here again, you see that I already have the restoration for the diastema closure for that tooth also. See, I still have a lot of enamel on this sizal edge, and I can remove a little bit over there because that's where I want more space to do all the characterizations. Okay, so very carefully I'm finishing my preparation here. Okay, so it's a preparation, as I said before, very similar to a ceramic veneer. That's it. Okay, this is the final preparation, as you see here. You can see that there is a large area of dentin exposed, but on the other hand, I think I have a lot of enamel preserved, especially on the periphery of my preparation. So I still have a lot of enamel, which is a good thing when we think about the longevity of that restoration, okay? Because bonding to enamel tend to last longer than bonding to dentin, especially if dentin is exposed to the oral cavity, okay? Which is not the case here because we have enamel all over the preparation, which is very good, okay? So we're going to start doing the restoration. Oh, one more thing. I could have used it here, the rubber dam, but I don't know if you remember, but the level of the gingiva in this tooth was higher, was more apical than the level of the gingiva of the other central. So I didn't want to put a clamp over there that would traumatize the gingiva. But I have the rubber dam right beside me. As I said before, as I'm looking through the microscope, if I see that there is bleeding or there's any type of contamination of my restoration, of my adhesive, I will stop everything and I get the rubber dam and I'll sit it on. Okay, so here the patient has a healthy gingiva. I exchange it, the retraction cord, I put another one, a clean one, and now I'm going to start doing my restoration without the rubber dam. And as I said, if needed, the rubber dam is right beside me. I'll just grab it and use it, but I didn't have to do it in this case. Okay, we could control the moisture from the gingiva. So here we did total edge technique. Okay, we're going to use the universal adhesive from 3M. We're going to evaporate the solvent. We're going to polymerize it first, and now we're going to apply the Empress Direct Opaque. Springly, we have to sprinkle it on the surface of the tooth. Okay, you're not supposed to do one smooth layer of opaque. Okay, it's supposed to be like that. Okay, so that the light, when it hits there, it will spread around. Okay, this is how it's supposed to look like. Now I'm going to be using the dentin composite from Ivoclar, from Empress Direct. The final color of that tooth is A1. Okay, usually when we use the dentin, we use dentin a hue darker than the, one chroma darker, a little darker than the hue we want to achieve. So in this case, if it's A1, the color I want to reach at the end of my restoration, if it's A1, I'm going to use a dentin A2. Okay, why? Because dentin is more opaque, so it reflects more light, so it seems that it's more it's lighter, it's a lighter shade of composite, so we use it a darker chroma. Okay, and of course at the cervical area we're going to use as the final color A2. So in the cervical area I'm going to use A3 dentin, which is it's exactly what I'm doing there. After polymerizing it, I'm going to use the A2 on the middle and incisal thirds. Okay, and also I'm going to put a mylar stripe on the mesial and try to pack it a little more of that composite onto the proximal area. So it's still the same dentin composite. Okay, the same dentin composite. I'm doing that on the mesial and on the distal. I mean, the whole surface of the tooth will be covered by dentin composite, but a more opaque composite on top of that opaque layer. Okay, so sometimes we put too much dentin, but I don't worry about that. After I finish it, after it's polymerized, if I think I put too much, I can remove and make it a very even layer of dentin composite. That's exactly what I'm doing there. After I do that, as I did only on composite, I just put a little bit of more adhesive, the same adhesive. I evaporate very well the solvent, very well, okay? And I don't need to polymerize it, okay? I don't need to polymerize it. So now I'm going to do like the frame of the tooth. So I'm going to do the mesial wall and then the distal wall. So I use a mylar stripe and then I pull it from buccal to lingual. Okay, I pull it from buccal to lingual and I try to make, the contour, the proper contour of the mesial surface of the tooth. So I have there exactly my mesial frame. Okay, you see I'm doing it again. Okay, it's just one movement from buccal to lingual. Okay, I did that on the mesial and now I'm doing again on the distal of that tooth. You see, always pulling down always pulling the mylar stripe, okay, in one continuous movement. Okay, now I'm going to use the Renamo microfill, which is a very good restoration to use as the last layer of your composite restoration, because it has the best polishing and it lasts for a very, very long time. Okay, so I'm using the A2 on the cervical area, as I said before. Okay, the A2, being very careful to see if there's no contamination coming from the gingiva. Okay, and now I'm going to use the A1 all over the tooth. Okay, all over the tooth. Okay, very close to those frames that I did on mesial and on the distal. Of course, that at the incisal third, I'm going to be removing a little bit of that composite in order for me to have those areas of low value, okay, of low value. So, again, if I didn't remove it too much, I can always prepare it a little bit. You see, there are some areas where I'm going to have more darker, more a lower value, Therefore, I will have to create that space for the next layers. Okay, so here I'm going to do the acid. I'm going to use a little bit of phosphoric acid just to clean the composite, and also maybe if I hit some enamel on the incisal edge, it will condition that part also. It will etch that enamel also. Okay, so I'm doing that. I will wash it out. I will dry it very thoroughly, and then I'm going to use my adhesive again, evaporate very well the solvent. I won't polymerize it. And now I'm going to do some stains. Okay, I'm going to use the blue, the violet, okay, for the low value areas, and I'm going to use the white stains. Okay, I can also use a little bit of brown stain in this case. Okay, so here it is. Now I'm going to put a little bit more of the A1, okay, my chromatic enamel, A1 again, and I'm going to create some grooves at the same areas where I want the low value. When I say low value, I hope you understand me. I mean a more gray area, okay, a kind of a gray area, okay, and also in this very thin layer, another layer, okay, the same material that I used before, which is the A1 from Renamo microfill. In this layer, I'm going to reproduce the crack that tooth has on the other, that the other tooth has right here at the distal area. So the right central, tooth number 8, has a crack close to the distal. So I'm going to reproduce it using a mylar stripe, okay, a mylar stripe, and I'm going to do a very thin mylar stripe. I'm going to do like a cut on the composite, on the non-polymerized composite. You see, I just cut it there. I polymerize it, and now I'm going to put a little bit of white stain and remove it. I put the white stain and then I remove all the excess just to leave a little bit at the bottom of that groove. Okay, and now I'm going to finish it with an incisal light microfill, Renamo microfill, okay, which is an achromatic enamel. Achromatic enamel. When we finish that, we never know if the restoration is okay or not, because even though I'm not using a rubber dam, the other teeth will be dehydrated, so they will be lighter. The white stains will be showing more, so we never know if it's okay or not. So I already rescheduled this patient, and I always do that 3 or 4 days after that. So at this point, I'll just do minor adjustments, okay, a pre-polishing, and then I'll send patient home. The next time I can do 2 things, okay? This is how it finishes. I just removed the retraction cord. That's why the gingiva is a little bit like that. So when I finish it, it looks okay, but I never know. You never know. because the other teeth, as I said before, looks wider, they look wider, they look brighter because they're desiccated, okay? So after 3 4 days, in this case after 1 week, this is the result, okay? It's not exactly the same. The low value area on the distal of my restoration is a little bit darker than the original tooth of the patient. The crack shows too much, but patient was very happy, and I wouldn't do anything. That's one thing that we do. The second thing that we can do in this second appointment is, if necessary, you do some adjustments. Okay, if the restoration is too dark, you can use a lighter composite. If it's too light, you can use a darker composite. I mean, you can fix it. And that's the beauty of doing this restoration with composites. Okay, because if you do it with ceramics, you think it's going to be easier. Oh, you just prepare it, send it to the lab, and they will send you, a very beautiful ceramic veneer. But when you cement it, something is going to happen, okay? Because there is an influence, about a 30 to 10% of influence of the cement, of the polymerized cement on your final result. And if after 1 week, the patient tells you, I think it's too dark still, or I think it's too bright, it's different from the other teeth. You know what you have to do? You're going to have to remove everything and begin from the start, okay? And you have to start all over again. You have to prepare it again, you have to remove the ceramics, you have to take an impression, send it to the lab, pay another one, okay? But if you did it in composite, if the patient complains about anything, you can fix it. Actually, you can fix it as many times as you want. That's why I think that in a case like that, composites are the best option, always. And you can think it's too complicated. Well, it is, but you just practice, and once you master it, it's very good, it's very fun, it's very rewarding to do something like that, okay? So these are the materials that I used, as I mentioned before. This is the before and after. Of course, after I finished, the patient realized that she had, different levels of gingiva from right side of the mouth and left side of the mouth. And then she wanted me to do something. Of course, if I just do a gingivectomy, to make her right gingiva on the lateral and canine to be the same as on the left side, I will have to expose some root dentin, which is not ideal. Not ideal. Okay, so I would need to do a graft on the left side and a gingivectomy on the right side, and the patient didn't want to do that. So just to do something for her, just to do something, respecting the depth of the sulcus, I did just a little gingivectomy, a very light gingivectomy with a diode laser, okay, respecting the depth of the sulcus, as you can see there, okay, just respecting the depth of the sulcus, you see, very, very mild, let's say, a very soft gingivectomy, okay, on the tooth number 8, 7, and 6, okay, that's it. And this is the final result. It's not exactly the same level, but it's pretty close, and patient was very happy, and we were happy too. This is the final case, okay, before and after. And here's the case after 6 years. Things change after 6 years. The patient did a little bit of bleaching. Of course, the other teeth bleached. The one I restored didn't. But still, patient is satisfied. What we ask for the patient at this point is, what do you think of your restoration? If they say it's wonderful, don't do anything, please. Just do a little polishing, just with a polishing paste and a felt, something very light, and that's it. This is the appearance of the composite, of the Renamel composite, after 6 years without doing anything. Okay? Here's a closer look. Okay? So you can see that on tooth number 8, where I did that, just the diastema closure, you can see there is a little bit, there's kind of a step on the mesioincisal angle, but the patient didn't didn't want me to do anything over there, so I didn't do it. I didn't do it. Okay, we have to respect what the patient thinks. So here is before, 1 week after. Actually, this picture is about 1 month after. Okay, 1 month after the restoration, and here 6 years after. So, as I said before, this is a very complicated, a very complex restoration. We have many layers, but in this case, this is the best, in my opinion, the best option we have to provide a good restoration aesthetically and long lasting for the patient. Okay? And could it be more simple? I don't think it could be more simple in this situation. But there are situations with a dark tooth that we can do a more simple restoration. But that's something we will be discussing in another time. Okay? Thank you very much for watching. See you on our next Dental Talk Without Secrets. Bye.